If you have with me, hello.
Yes, sir. I give you count. After my countdown, you can start.
Okay, okay.
Yeah. So we are starting in 3, 2, 1. Please start, sir. We are live.
Okay. So very good evening. Warm welcome on regards of Bayer Oncology and from Team Newbeka. In this clinical conversation of Newbeka, today with us to going to welcome our honorable speaker, Dr. Ranveer Shah, sir, who is a very much rich experience previously with Tata Medical Center, Kolkata, and now also with the Apollo Multi-Speciality Hospital, Kolkata. He is a senior consultant clinical oncology from Apollo Hospital, Kolkata. And for this session, I will going to invite sir for his session on the topic is breaking barriers in MHSPC doublet with dermatomyes plus ADT. So welcome, sir, on behalf of Bayer Oncology, myself, Stagnik, welcoming you for this session, sir. Very welcome, sir.
Thank you for your kind introduction. Uh,
Thank you, sir.
am I audible?
Yes, sir. Very much audible, sir.
Yeah. So I'm sharing my slide.
Sure, sure, sir.
Is my slide visible?
Yes, perfectly, sir. It's very much visible.
So thank you, Bayar Oncology, for giving me this opportunity to interact with you. And today's topic of discussion is breaking barriers in metastatic hormone-sensitive prostate cancer. Doublets, uh, darolutamide plus ADT leads the way with Aranot. So I'm a clinical oncologist working in Apollo Hospital, Kolkata. These are my disclosures. So the standard of care in metastatic hormone-sensitive prostate cancer has evolved with time. Uh, and over time, we have seen different combinations, backbone being ADT, and people have added docetaxel, abiraterone, enzalutamide, apalutamide, and triplet therapy also with abiraterone plus ADT plus docetaxel. And Bayer is also bringing new stuff in the armamentarium uh, because despite treatment with ARPI and ADT or docetaxel plus ADT, large proportion of patients with metastatic hormone-sensitive prostate cancer will progress to MR MCRCPC within 3 years. So we got darolutamide plus ADT plus docetaxel in the first line setting in the RSM, and today we'll be discussing about mainly the Aranode, darolutamide plus ADT, where we are sparing docetaxel and establishing as a reasonable option for treatment in metastatic HRBC, HSBC. So there is an unmet medical need remains for the efficacious treatment that offers a differentiated and improved safety profile of patients with metastatic hormone-sensitive prostate cancer without adding significant toxicities and with a low drug-to-drug interaction potential. We have seen RSMs uh, which showed all beneficial efficacy and safety profile in metastatic HSPC patient leading to approval in 2023. Darolutamide in combination with ADT would provide efficacy benefit with a favorable safety profile in metastatic HSPC, as demonstrated in the global phase 3 study Aranode trial with significant Indian patients. With Aranode data, darolutamide has potential to change the treatment paradigm, as now it would be the only ARPI which could be used with or without chemotherapy. So darolutamide plus ADT with docetaxel is standard treatment for metastatic hormone-sensitive prostate cancer as per the Aracin study, and Aranaut was designed to evaluate doublet darolutamide plus ADT versus ADT plus placebo to provide a new treatment option in patients without osteoporosis, because the significant proportion of patients who are not a fit candidate for the treatment therapy. So this is the trial design. Randomization was 2:1. Darolutamide 600 milligram twice daily plus ADT was compared with placebo plus ADT. Primary endpoint was radiological progression-free survival, and key secondary endpoint was overall survival, time to initiation of subsequent antineoplastic therapy, time to CRPC, time to PSA progression, rate of undetectable PSA, time to pain progression, safety, etc. And as you can see, the patient demographic and clinical characteristics at baseline were equally balanced in the two groups. Country representation across breakthrough clinical trials for prostate cancer treatment. What's special about Aranaut trial that a significant patient proportion was belong to the Asian continent, India, China, Taiwan, etc. So it showed that darolutamide plus ADT significantly reduced the risk of radiological progression or death by about 46% versus placebo plus ADT. And the benefit of darolutamide plus ADT on radiological progression-free survival was consistent across subgroups, including patients with high and low volume disease. So darolutamide plus ADT demonstrated a benefit across all secondary endpoints, be it in time to metastatic CRPC, time to PSA progression, time to initiation of subsequent therapy, time to pain progression, etc. At the time of primary analysis, OS data was immature. If OS is immature, patient will be followed for survival. So darolutamide plus ADT delayed time to CRPC and time to pain progression. You can see from this Kaplan-Meier curve, these curves are well separated. Darolutamide plus ADT also achieved deep and durable PSA response. As you can see, about 62% patient with the darolutamide arm and 18.5% patient in the placebo arm achieved less than 0.2 nanogram per ml at any time during treatment. And time to PSA progression was also prolonged with darolutamide significantly. Higher proportion of patients achieved undetectable PSA with darolutamide versus placebo in both high volume and low volume subgroup. As we have mentioned, the benefit was similar across both high volume and low volume disease patients. And subsequent life prolonging anti-cancer therapy was used less commonly with the darolutamide arm compared to placebo arm. The incidence of treatment-related adverse events were similar between the treatment group, and the discontinuation were lower in the darolutamide arm. So any AE was about 90% in both the arms. Grade 3 or 4 AE was about 30% in both the arms. Grade 5 AE was 4.7% with darolutamide and 5.4% placebo. So hardly any difference. Adverse event leading to permanent discontinuation of darolutamide was not significantly more with darolutamide, and median treatment duration was 24 months with darolutamide and 17 months with placebo. So the safety profile of darolutamide in adults was independent of PSA response and consistent with favorable tolerability first seen in Aramis and Aracins. Rates of the common AE were low and similar between the treatment arms. The rates of AE commonly associated with ARPI was similar across the treatment arms. Darolutamide confers a positive impact on health and quality of life. It extended median time to deterioration of fat total score by 5.1 months versus placebo. Darolutamide is the first and only AR inhibitors to demonstrate clinically meaningful delays in pain progression and overall well-being. This drug doublet therapy demonstrates clinically meaningful delays in deterioration of overall well-being, especially on social, functional, and urinary symptom domain. In conclusion, darolutamide plus AD significantly improved regulatory progression-free survival in patients with metastatic HSPC. It showed a benefit across all secondary endpoints. OS data was immature. Darolutamide was associated with a deep PSA response regardless of baseline PSA. It is the first and the only AR inhibitor to demonstrate clinically meaningful delay in pain progression, overall well-being, including social, familial well-being, functional well-being, and urinary symptoms. And darolutamide is a very favorable safety profile compared to placebo. So darolutamide plus ADT without docetaxel should become an additional standard of care in metastatic hormone-sensitive prostate cancer, particularly in patients who are not fit or unsuitable for triplet therapy. That's all for me. Thank you for your kind listening.
Thank you, sir. Thank you for your nice presentations, and it's a very much collaborative session and session with our doublet option. So thank you very much. So if anybody having any questions, just you kindly wait for a minute, then we can conclude the session. You can switch off your camera. So I think there is no such kind of questions from audience. So with your permission, sir, we can go forward to conclude the session. If you kindly allow us, sir. Thanks for your nice presentation.
Sure, thank you. Go ahead.
Okay, okay. Thank you, sir. So taking, we can conclude the session.
Okay, sir.
Thank you. Good night,
Thank you.
everyone.
Good night. Good night.